action.
All right, dear colleagues from the United States and around the world, we welcome you all. It is an honor to host you at American Heart and Vascular Institute series of webinars. This will be our third session, and you can review our previous session on our YouTube channel. And we are so thrilled and excited to host faculty, world-class faculty from around the world. And most importantly, the leading figures and leaders in women cardiology. And I'm very happy to moderate, co-moderate, and co-host this session with Dr. Martha Gulati, who needs no introduction, and Viet Lee from Salt Lake City, we're great friends. And we are thankful to Steward Health for giving us, providing us CMEs for this talk. So just some basic stuff. Again, this is all the faculty that we have. And we have no financial disclosures for this talk. American Heart and Vascular Institute, we are not getting paid, and all the faculty are required to fulfill all the CME requirements. To claim CME credit, you can visit this site, or you can use this barcode for ABIM MOC credits. Again, you can visit this website or use this barcode. This video is recorded, which will be uploaded on our YouTube channel, as you can see. And if you have any questions regarding CME credits or certificate, please email Carrie Roberts. This is her email. Without further ado, because of the time, we have kept all the talks for 10 to 12 minutes. And this 1.5 hour session will be very intense, action-packed, full of knowledge. And we will take questions at the end of all the talks. If you have any questions, you can type in your comments in the chat box. And at the end of the session, you can raise your hands. We can unlock your video, and you can directly talk to or ask questions to any faculty. Dr. Gulati, if you have any comments, please go ahead. If not, we can start with the session. Dr. Gulati?
Yeah, no, I have nothing to add to that except to thank all our speakers for agreeing to do this with us, and for all the people in attendance. We're expecting over 400 people, and I know people will be trickling in and also watching on their own. So thank you, everyone.
All right, guys, so let's start off with practical tips on the management of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction in 2020. And the speaker is Dr. Nasreen Ibrahim from Harvard Medical School. She is an assistant professor there. She's also heart failure transplant cardiologist at Mass General Hospital. Dr. Ibrahim?
All right, if you can stop sharing so I can share my screen.
All right, here we go. So, sorry about that. Okay.
All right, I'm very excited to be here. Thank you everyone for having me. And I only have 10 to 12 minutes to give you the high yield tips for management of HFrEF and HFpEF. So we're gonna get started. These are my disclosures. So heart failure and reduced ejection fraction. These are exciting consults for me because we have medications that we know reduce morbidity and mortality, hence the thumbs up sign. ARNIs, the only one we have right now that's approved and on the market is sacubitril valsartan. And as you know, we choose ARNI over ACE or an ARB because of the increased reduction in mortality and morbidity. Beta blockers, the only 3 beta blockers that are on the guidelines that we should be using are carvedilol, bisoprolol, and metoprolol succinate. So that's the long-acting version of metoprolol. Mineralocorticoid receptor antagonists, including eplerenone and spironolactone. And then finally, SGLT2 inhibitors, which are not yet on the guidelines, but I am guessing they will be on the next iteration of the guidelines and consensus documents. And Dr. Kittleson will be going over SGLT2 inhibitors in more detail with you. But this is the armamentarium of drugs we can use for HFrEF. I'll start with a case and I'll just be reading through it and going over how I think about a patient like this. So this is a 68-year-old man with a history of HFrEF attributed to ischemic cardiomyopathy, admitted initially to the CCU in acute decompensated heart failure. He's essentially in cardiogenic shock on arrival and is receiving dobutamine during the initial part of his hospitalization. He's now been out of the CCU for 48 hours. Blood pressure is 98/62. His heart rate is 99. And you're asked to see him to optimize his GDMT. He's currently on metoprolol succinate, 50 milligrams twice a day, lisinopril 10, furosemide 40. Lab data are unremarkable. So which of the following is the next best step? Increase lisinopril to 20 milligrams daily, stop lisinopril and add sacubitril valsartan, C, add spironolactone, or D, increase metoprolol succinate to 75 twice a day. Everybody knows I love ARNIs, but that is not the answer. So here the answer is add spironolactone 25 milligrams daily. And the reason being, we get the data about initiation of ARNI in patients with acute decompensated heart failure from PIONEER-HF, where patients were randomized to receive sacubitril valsartan or enalapril. But the important thing to remember is that these patients were stable. So in the last 6 hours before initiation or randomization, their systolic blood pressure was 100 or greater, and then they were off of inotropic agents over 24 hours. So because this patient has a marginal blood pressure, I would start with spironolactone first, and maybe later on in the hospitalization, if the blood pressure is 100 or greater, then we would stop the lisinopril, wait for that 36-hour washout period, and start the ARNI, preferably before discharge. And so PIONEER, the primary endpoint was reduction in NT-proBNP 8 weeks after randomization. And then the secondary endpoint was the reduction in cardiovascular death or heart failure hospitalizations. And we know patients that received sacubitril valsartan had a greater reduction of the combination of CV death or hospitalization for heart failure. What's also important to note that there was a pre-specified subgroup of patients in PIONEER-HF. There was about 300 patients that had not been on an ACE or an ARB, and these patients had similar reduction in NT-proBNP with sacubitril valsartan, and their safety profile was similar to patients that had been on an ACE or an ARB and then switched to an ARNI. What about de novo ARNI in chronic heart failure? It's not on the guidelines. Maybe it'll be on the next iteration of the guidelines, but there is this consensus document. Full disclosure, I am one of the authors of this consensus document, where we say it is reasonable to start patients with a new diagnosis of HFrEF that have not been on an ACE or an ARB in the clinical setting. So these are chronic HFrEF patients. It's based on patient preference and also making sure blood pressure is okay, potassium's okay, creatinine's okay. So it's not unreasonable to start patients de novo on ARNIs when you first meet them. So the second case is a patient with a new diagnosis of HFrEF attributed to non-ischemic cardiomyopathy with an EF of 25% and New York Heart Association symptoms, class 2 symptoms. Do you, A, maximize the beta blocker before adding an ARNI, add low-dose ARNI to low-dose beta blocker, maximize the ARNI before adding an MRA, or add low doses of all 3 classes of meds? Trick question, because any of these would be okay. It really depends on the clinical scenario, the attending preference, and so it's important to look at the clinical picture when you're making that decision. So I wanted to go over what I would do, what my approach would be in a patient who's quote unquote wet. So I would start with an ARNI, and I would add a mineralocorticoid receptor antagonist. I usually add them at the same time and just start with a low dose of, say, 12.5 of spironolactone. Maximize the ARNI, but it's really important to remember to assess whether or not you need to reduce the diuretic. We know when we start patients on sacubitril valsartan, they have diuresis. And so you need to decide, do you need to stop the diuretic? Do you need to just cut it in half or reduce it by a third? And it really depends on the clinical scenario. And a lot of times I use the NT-proBNP to help me. So if a patient's NT-proBNP is 30, I'm probably thinking more so about being more aggressive with reducing the diuretic as opposed to a patient who's somewhat wet with an NT-proBNP greater than 1,000. When they're dry, that's when you add the beta blocker, and you don't titrate it as fast as you would an ARNI. You probably would do that every 2 weeks. Again, every patient scenario is different. And then finally, where does the SGLT2 inhibitor fit in? I would say at really any point along this timeline, it's important to just have a plan of when to start it. We know that we also get some diuresis with the SGLT2 inhibitors, so you have to make the decision about whether or not you need to reduce diuretic. And what about patients with marginal blood pressure? We get this question all the time. When do you stop pushing GDMT? So symptoms are more important than numbers. I start to worry when the systolic blood pressure is less than 90. Make sure to discontinue non-GDMT medications. The usual culprit are calcium channel blockers like amlodipine. Those don't reduce morbidity and mortality, so you should stop them in preference of drugs that do reduce morbidity and mortality. Remember to reduce diuretic doses in patients that you're starting or maximizing ARNIs and SGLT2 inhibitors on. Go slow. Some patients may need more time to adjust to new medications. And then remember, everybody's maximum tolerated may not be the target doses in trials. So many options with HFrEF. I get this question a lot too. What if you had to choose between a beta blocker and an ARNI, which one would you pick? Well, it depends. For patients that have marginal cardiac output and index, which is most of the patients that I see, I choose to optimize the ARNI over the beta blocker. If you're looking just for mortality benefit, maybe optimize the beta blocker over the ARNI, because as you see here, the beta blockers have the biggest reduction in mortality, biggest bang for your buck. Or you can go with low doses of both. So this slide is courtesy of Dr. Fonero. 4 pillars that improve survival in HFrEF. It's really a 4-drug regimen now. So ARNIs, beta blockers, MRA, and SGLT2 inhibitors. And this is how I feel when I get a consult for heart failure with preserved ejection fraction, because we really don't have the armamentarium that we have for HFrEF. There are no class 1 indications that reduce mortality in this patient population. So we have 2 class 1 recommendations that reduce morbidity. So we have class 1 recommendation for blood pressure control according to published guidelines, and we have a class 1 recommendations for diuretic to relieve symptoms. We have several class 2A recommendations, and these recommendations are things that are reasonable for you to do. Patients that have coronary artery disease and have symptoms despite medications, you can consider revascularizing them. Patients with atrial fibrillation, you can consider treatment of the AFib either with medications, antiarrhythmics, or via catheter ablations in patients that are symptomatic. And then beta blockers, ACEs, and ARBs. And in specifically certain selected patients that have an EF 45% or greater and have a history of heart failure hospitalization and elevated NT-proBNP, mineralocorticoid receptor antagonists may reduce hospitalization. And then finally, there is no benefit for routine use of supplements, and there is no benefit in routine use of nitrates or phosphodiesterase 5 inhibitors. So in conclusion, HFrEF, you really have a great a big armamentarium of medications that we know reduce morbidity and mortality, and all patients with HFrEF should be on these 4 classes of medications, and if they're not, you need a really good reason why not. So it's important to not just start the medications, but also optimize them to the maximum tolerated doses. And then lastly, for HFpEF, blood pressure control, diuretics, weight loss, exercise, and control of comorbidities. So thank you, and I will take questions at the end.
Thank you, Dr. Ibrahim. That was a very detailed talk that you put together in 10 to 12 minutes, and I'm sure it was very, very hard, but the job well done. Next, we're going to invite Dr. Martha Gulati to talk about sex differences in heart failure and how we can avoid, I would say, biases in treatment of heart failure in women. So, Dr. Gulati, please.
Yes, thank you. And thanks. It's hard to be with this entire crowd because I am not somebody who is a heart failure expert, but I do look at the differences between men and women. So for more in-depth questions, I'd say ask all the experts on this, but I'm going to point out some of the sex differences. All right, let me just get this to change. All right, I have no disclosures. As everyone here knows, that cardiovascular disease is the #1 killer of women, and it accounts in the United States for over 400,000 deaths in every year. The prevalence of cardiovascular disease is huge in the United States, and almost 1 in 2 women live with some form of cardiovascular disease, and 6.5 million adults have heart failure. That ultimately contributes to 1 in 8 deaths due to heart failure, and the lifetime risk for heart failure in women is 1 in 5, which makes it obviously an issue that everyone encounters, whether you're in primary care, whether you're a cardiologist. So I'm going to just point out some of the differences of what we know about women, and a lot of this has to do with the sex differences in our research relating to heart failure. And as you can see from this paper that came out earlier this year, when we look at studies and stratify them in many different ways, we're able to find out where we've under-enrolled women. And this is adjusted for participation based on prevalence of the disease. And you can see that we really under-enroll women in almost every type of study, but particularly heart failure and coronary artery disease, which are often linked together, devices and procedures, which again affect patients with heart failure. And surprisingly, studies that are funded by the government are even less likely to enroll women. So whenever you look at a study, I always look first to see how many women were enrolled to even know if it applies well to women. Oh, sorry. And why does it matter? Well, sex matters. I mean, sex is the biological differences between men and women, and every cell in our body has a sex. And so we need to know what are the biological influences as much as we need to know what are the gender influences. And all of these things listed on this slide are important for us to be asking about when we're looking at differences between men and women. But what are some things that are unique to women? Well, some of the risk factors that affect heart failure are unique. And let's just go through them quickly. So diabetes, certainly more prevalent in women. And when a woman has diabetes, it's actually a greater risk factor for heart failure than it is for men. And additionally, there's differences in how the left ventricle remodels in diabetics, and specifically based on sex. For women, there's more left ventricular remodeling, an increase in the mass and the wall thickness. Obesity is certainly more prevalent in women than it is in men, and it is a stronger risk factor for heart failure with preserved ejection fraction than a heart failure with reduced ejection fraction. And when you have the triad of diabetes, obesity, and heart failure in women, we know that there's more inflammation. And again, that sort of triad is more likely to be associated with heart failure with preserved ejection fraction. Hypertension as well, it poses a greater risk for heart failure in women, as we saw in the Framingham's heart study. And there's different patterns that we see with an increase in LV mass. For women, we see a more concentric LVH, whereas for men, it's more eccentric. Tobacco use is actually a stronger risk factor for heart failure in women than it is in men. So, and then additionally, it has a greater risk for association actually with peripartum cardiomyopathy if you smoke. So these are things that might only affect women or are female predominant in terms of the risk factor impact. So there are some sex-specific issues related to heart failure. Things like peripartum cardiomyopathy obviously only occur in women. And we know pregnancy as we talk about it as a stress test. It stresses the cardiovascular system, but it also announces differences in the endothelial function and increases inflammation and can predispose them to the development of heart failure. And we know that when patients have preeclampsia during their pregnancy, not only are they more likely to go on and have more coronary artery disease in the future, but they're more likely to develop heart failure, including peripartum cardiomyopathy. Worldwide, pericardium cardiomyopathy affects 1 in 1,000 pregnancies, but obviously there's some geographic variability. And to date, we have no specific diagnostic biomarker that is established for peripartum cardiomyopathy. Now, breast cancer obviously occurs much more frequently in women than in men, and there is an increase in the development of heart failure based on the treatments that we give for breast cancer. And as women are more likely to survive the cancer, we're seeing that women who are breast cancer survivors are more likely to actually die from cardiovascular disease. And in fact, women have been shown to have a greater predilection for anthracycline-induced cardiotoxicities compared with men. And it may be a difference in pharmacokinetics, which I'll briefly touch on. But again, the breast cancer therapy Herceptin, women have about a 13% greater risk of developing heart failure. And if they get Herceptin along with anthracyclines, the risk is even greater. And even radiation therapy has also been associated with the development of heart failure, but specifically heart failure with preserved ejection fraction. There is some sex differences in the pathophysiology of heart failure, and the lifetime risk for men and women is about the same as men. Certainly for both men and women, with increasing age, there's a greater risk of development of heart failure. But where the differences exist is the forms of heart failure. For women, it's much more likely for them to have heart failure with preserved ejection fraction, and for men, it's more likely that they can develop heart failure with reduced ejection fraction. And this pathophysiology of heart failure with preserved ejection fraction seems to be on the same continuum as INOCA, or ischemia with no obstructive coronary artery disease, that these having traditional risk factors, chronic inflammation, and aging can go in two different directions. You can see them pronounced as INOCA, or you may see them pronounced as heart failure with preserved ejection fraction. And this idea of pro-inflammation, as we know, is much more common in women, and therefore this disease pattern is more likely seen in women. There's many things that are unique that we've noticed in women. As I already talked about the risk with hypertension. Again, I already spoke about the risk with preeclampsia and obesity. But autoimmune diseases, again, greater likelihood in women, diseases of inflammation, and they frequently contribute to diastolic dysfunction. Diabetes, I also talked about its association with systemic inflammation, but even iron deficiency, which again is more common in women than in men, and is associated with the development of heart failure. It's associated with this increased oxidative stress, which they believe could contribute to the development of heart failure. Another sex-specific issue, as everyone knows, is the Takotsubo's cardiomyopathy, also known as stress cardiomyopathy, and it has one of the most uneven sex distributions, for about a 9-to-1 ratio for women. And as I think most of you know, that there's usually triggered by an emotional or psychological stressor that is postulated to increase catecholamine surge and result in myocardial damage. And again, this is much more frequently seen in women. There's data showing that women actually have more stress-induced myocardial ischemia, greater platelet reactivity than we see in men. So this is one disease, I don't have enough time to go into all of it, but this is one that obviously affects women. So it's important to appreciate these sex differences. And I kind of went through most of this. Women actually have better survival than men, but they have a poor quality of life, poor functional capacity. Just quickly, I just wanted to touch on differences in pharmacotherapy, just to be aware. We know that when we look at just blood concentrations of drugs, that they are often higher at the same doses in women compared with men. And there's differences, it may be body composition, it may be in clearance of these drugs, but it's important to recognize that, because we do know that when women peak, when they get the greater benefit of these drugs, it often is when they only have 50 to 60% of the guideline recommended dose of the drugs, in contrast with men who continue to get the benefit when the drug is increased. And it may be that we need sex-based dose targets for the treatment of heart failure with reduced ejection fraction, but the problem is we just don't have the data on that, and the trials weren't done in that way. But I will just point out, like for example, the Atlas trial that compared low versus high dose lisinopril in heart failure with reduced ejection fraction, saw that men were benefiting from the high doses compared to women. The HEAL trial, again, compared high versus low doses of losartan. And again, with the higher dose, it was much more beneficial for men, but the women had equal effect with either dose. Digoxin, women with had actually higher concentration of digoxin in the system and actually had a higher risk of death with digoxin. So again, for heart failure with preserved ejection fraction, this is where we're seeing in the Paragon heart failure trial specifically that there was a benefit with these drugs, the ARNIs, as were discussed earlier, in women compared with men who had heart failure with preserved ejection fraction, and there was no effect seen in men. And this may be a unique treatment in this particular population for women. And that's because that study went out of its way to specifically enroll enough women, and it was a pre-specified sex analysis that they planned for. I don't have enough time to talk about all the sex differences, obviously, but there's sex differences in device therapies and transplant for heart failure. Just quickly here, women are less likely to be transplanted. They're less likely to be listed as part of that problem. They're less likely to be listed on the list that gets them transplant earlier. And early on, there may be some differences in survival, but long-term survival, women actually have a better survival after transplant. So it's just important for us to always look at what are the differences and where does the work need to be done so that we can have better outcomes for women. So I hope that I was able to point out in a very quick fashion the sex differences in both inclusion of women in the trials, the risk factors for heart failure and the different types of heart failure, and perhaps where we need to go in terms of medications. So thank you, and again, I'll take questions at the end.
Well, Dr. Gulati, it was such a masterful performance and covering of this very, I would say, tough talk. And I personally have learned a few things. And next, Dr. Lee, you want to introduce Dr. Kittleson?
Yeah, thank you. So again, that was a very complex topic and continues to be. So thank you, Dr. Gulati. So next up, we're going to be speaking well, actually, Dr. Kittleson will be speaking to us. She comes to us from the Smith Heart Institute at Cedars-Sinai, and I'm excited to hear about the new medications for heart failure, the SGLT2 inhibitors. I'm kind of a fan of these medications and especially the data on them. So I'm very curious as to your take, Dr. Kittleson, as well as on vericiguat. And boy, that trial didn't look too good. So I'd like to see what your take is. So we'll turn it over to you.
Can you hear me? Yes. Yes.
Yes,
I'm nodding. Okay. And I know I'm going to share my slides. Sorry, technology often befuddles me. Slideshow. Is the slideshow going?
It is on, and I think you'll just need to click on the bottom there at the, oh, you know what? You may have presenter view on somewhere. That happens sometimes for folks using PowerPoint. So if you've hit the presenter button down below, okay. There you go.
Okay,
yep.
Great. All right. Sorry, guys. It took a pandemic for me to learn how to use FaceTime, so you understand my level of understanding of technology. So delighted to be part of this esteemed panel to talk to you guys about the SGLT2 inhibitors and vericiguat. So I have no disclosure. So Dr. Ibrahim so elegantly gave you the armamentarium of guideline-directed medical therapy for heart failure, where there's a stepwise approach to therapy based on symptoms and other criteria. And we're going to talk about where dapagliflozin and vericiguat may fit into this established armamentarium. So let's start with dapagliflozin, the SGLT2 inhibitors. Now, the SGLT2 inhibitors have many magical and mysterious effects that aren't not well understood. What do we know? It causes glucosuria, and through that, improves glycemic control. It causes natriuresis and therefore relieves congestion, can lower blood pressure. But it also has these mysterious benefits of reduction in oxidative stress and fibrosis and inflammation. And through those effects is thought to exert its benefit to the kidneys and to the heart. And when we think about the important SGLT2 inhibitor trials for patients with cardiovascular disease, they're shown here. And these 4 trials owe everything to rosiglitazone. What? Rosiglitazone? That's a thiazolidinedione. What is she talking about? Well, rosiglitazone back in the 2000s was used to treat diabetes because it lowered hemoglobin A1C, a surrogate endpoint, when lo and behold, studies then showed it increased the risk of heart failure. And that inspired the FDA to then require that for a medicine to be approved for use in diabetics, it couldn't just improve a surrogate endpoint like A1C, it had to demonstrate safety for cardiovascular outcomes. And that ushered in the era of the diabetic cardiovascular outcomes trials, and empagliflozin, canagliflozin, dapagliflozin, and erdagliflozin were run through the gamut. And all these trials tested patients with type 2 diabetes and atherosclerotic cardiovascular disease and or multiple risk factors. And not only were they shown to be safe for patients with cardiovascular disease, there was this unexpected finding of efficacy, of benefit, of reduction in heart failure outcomes. It was like winning the lottery, akin to when that medication for vasodilation improved erectile dysfunction many years ago and everyone bought stock in sildenafil. The same kind of amazing serendipitous finding of the SGLT2 inhibitors in diabetics. So what did they know? They knew that SGLT2 inhibitors reduce heart failure in diabetic patients who don't even have heart failure. Well, if it helps so much in patients who don't even have heart failure, what about in diabetic patients with heart failure? It'd probably work even better. And the next step was when the clinical trial architects took a magical genius leap and said, wait a minute, why don't we just test it in heart failure patients who don't have diabetes? And that was the genius leap that led to the DAPA-HF trial. And the DAPA-HF trial was 4,700 patients, heart failure with reduced ejection fraction, symptomatic, not required to have diabetes for study entry. And lo and behold, with good baseline medical therapy, a reduction in cardiovascular death, a reduction in heart failure hospitalizations, a diabetes medication that worked in heart failure patients without diabetes. So the dapagliflozin isn't just for diabetes anymore. On September 1st, the DAPA-HF trial results were presented in Paris, France at the European Society of Cardiology meeting, and just 8 months later, the FDA indication for dapagliflozin was extended now to reduce the risk of cardiovascular death and hospitalizations for heart failure in adults with heart failure with reduced EF with and without type 2 diabetes. And to hammer that point home even more, because I'm so excited about this, let's look at the package insert. 3 main indications. If you're diabetic, take it to improve your diabetes. If you're diabetic, take it to reduce heart failure hospitalizations if you've got cardiovascular disease. And if you don't have diabetes, take it just if you have HFrEF to reduce the risk of death and hospitalizations for heart failure. Contraindications, always important to know. Remember the big 3, low GFR less than 30, on dialysis, type 1 diabetes. Those are the reasons not to give it. And even more exciting, it's not just dapagliflozin anymore. So the Emperor Reduced top-line results came out on July 30th, hot off the press. Empagliflozin was tested in patients with HFrEF with and without diabetes. So basically, empagliflozin's version of the DAPA-HF trial, and added to standard of care, reduced the risk of cardiovascular death and heart failure hospitalizations compared with placebo. I'd love to tell you more, but I can't. The results are coming out in 3 days at the European Society of Cardiology meeting, and this is what you're going to want to know. You're either going to be there virtually, or you're going to be on Twitter frantically searching for hashtags about the Emperor Reduced trial. And what you're going to find, what you'll want to know is, was there a reduction in the endpoint, single endpoint of cardiovascular death, or was the combined endpoint driven by heart failure hospitalizations? Were the patients on good baseline guideline directed medical therapy? How sick were they? What was their New York Heart Association class, EF, NT-proBNP, EGFR? In other words, how much were they, the patients in the trial, like the patients you treat? And was there the same benefit in diabetics or non-diabetics? So in 3 days, we will all be waiting with bated breath. So when I think about the SGLT2 inhibitors, they more than anything encapsulate how medicine is a team sport. The nephrologists love them. The endocrinologists love them. The cardiologists love them, which means by definition, primary care providers love them, because primary care providers wear every one of these hats. So we are all going to be prescribing these medications to help our patients with diabetes, with cardiovascular disease, with heart failure. So a few practical points. When you start a patient on an SGLT2 inhibitor, prepare them. They should watch out for volume depletion since it has natriuretic, diuretic properties, ketoacidosis in diabetics, urosepsis, pyelonephritis, it does cause glucosuria, genital mycotic infections, and rarely necrotizing fasciitis. So this is figures from a beautiful, helpful, practical review article. Discontinue non-evidence-based heart failure therapies when you start it. Consider measuring the Johnson levels. That's mainly with canagliflozin in the randomized trial. Adjust loop diuretics if needed because there will be some diuretic effects. Hold if temporarily ill with limited oral intake. Avoid excessive alcohol. Watch for volume depletion. Ensure appropriate perineal hygiene and foot care. And one good thing about medicine is you don't have to know everything. And this is when I would phone a friend, the endocrinologist, to ask for help and guidance. If I have a diabetic patient and I don't feel as comfortable managing a diabetic patient, I might call my friend, the endocrinologist, and say, does the patient have type 1 or type 2? Can you confirm for me? How should I adjust other oral diabetic therapy? What should I do with the insulin? Generally, if the type 2 diabetes is at or under glycemic targets, you can decrease or discontinue the sulfonylurea or the DPP4 inhibitor. Insulin titration, a little more tricky. So never be worried about phoning a friend and acting like this because medicine is ultimately a team sport. So that's the SGLT2 inhibitors. Let's touch briefly on vericiguat, briefly because it's not yet FDA approved, though it probably will be at some point, so keep it on your radar. A soluble guanylate cyclase stimulator that does good things through nitric oxide dependent and nitric oxide independent pathways to improve myocardial function, vascular function, endothelial function. So the Victoria trial came out earlier this year, 5,000 patients, heart failure with reduced EF, symptomatic, vericiguat versus placebo. The primary composite outcome was met, which was a combined endpoint of death from cardiovascular cause plus heart failure hospitalization. This was driven by heart failure hospitalizations, like 2% absolute risk reduction, 29% to 27%. There was good baseline medical therapy. I think vericiguat will enter our armamentarium in the next iteration of the heart failure guidelines. We'll have some guidance of where it enters the clinical pathway. So you heard it here first. You will remember this trial. You'll think about it in the next year when we have more data about it. So, but the bottom line is, with quadruple therapy as it currently exists, we can save a lot of lives. And Greg Fonroy was clearly amazing because I'm the second presenter to steal his slide. This is one of his amazing, powerful slides about the power of what we can do with pills and HFrEF. I might not be a fancy cardiothoracic surgeon who can crack people's chests open to save their lives, but I can still save lives with pills, right? You take someone with HFrEF, 2-year mortality, 35%. Add an ARNI, beta blocker, aldosterone antagonist, SGLT2 inhibitor, and all of a sudden their 2-year mortality is down to 9.5%. That's amazing. That's powerful. That is a reason to overcome therapeutic inertia. And it builds the foundation for a new era of quadruple therapy in heart failure. And if I haven't convinced you enough, think about this. So no one's ever going to do a randomized controlled trial of old conventional therapy, ACE inhibitor, beta blocker, versus new comprehensive therapy, the ARNI, beta blocker, MRA, SGLT2 inhibitor. But we can imagine such a trial through fancy statistical cross-trial analysis. And if we do imagine such a trial, what we would find is that comprehensive therapy versus conventional therapy gives patients an extra 6.3 years of life. We are just as cool as those surgeons who crack people's chests open. We can do so much with these pills. And just as a testament again to how cool Greg Fonero is, I'm using this slide too. Dr. Ibrahim, great minds think alike. If you see it once, you see it twice, you'll never forget it. The 4 pillars of HFrEF health. Avoid therapeutic inertia, overcome it, put your patients on these medicines, you will save their lives. So take home points. GDMT works. Aim for quadruple therapy. And if patients are not on it, ask yourself why. Thanks so much for your attention.
Wow, Michelle, that was fantastic.
Great.
What a great talk. All right, our next speaker can start putting up her slides, and I have the pleasure of introducing Dr. Eileen Hush, who is from the Cleveland Clinic and teaches me everything I know about devices, and so we have asked her to speak on that today.
I too am a little bit. Can you see my slides? But I'm still not in the.
Just go to slideshow and yeah, begin from the beginning. You've got it. We got them.
But it's not opening up. Why is that?
Yeah, you maybe also have presenter view in the background somewhere on a second screen. That's a common thing that happens with PowerPoint. It's one of my pet peeves of it. I'm trying to figure out though how best to.
So let me just go to the beginning. That looks good. I think so. Can you see?
We can't. Well, we can see your slides, but not in the presenter view here. I think it's in on your own computer.
So when you go, yeah, and when you go back to share slides, you can choose.
Escape for a second, and then you'll.
Sharing. Okay, so you see nothing right now. Is that correct?
Now we see you. And now share your screen again. Okay, hopefully. Just maybe, there we go. Perfect.
Okay, good, excellent. And I'm sorry for the slow start. I have to say, Dr. Kilson, you can sell me anything. I think I'd buy it. I'm not sure what you were selling, but I think I'd buy it, regardless. It was awesome, absolutely awesome. So I'm here to talk about when to consider heart failure devices. And really the topics are gonna be 3. We're gonna talk about defibrillators, we're gonna talk about biventricular pacemakers, and we're gonna talk about left ventricular assist devices that are used for 2 purposes. One actually as the last therapy, and that's why it's called destination. And the other as a bridge to transplant. So when we put in defibrillators, we're only doing it to actually save lives. So I want to be very clear, because one of my patients says, I assume I'm going to have a stronger heart or I'm going to feel better. And the answer is no, you're not. It's actually no different. I always joke that the very first defibrillator was really somebody who actually knew a lot about cars, and you're just jump starting your car. I mean, that's it. And actually, to really tell you a very interesting story, the guy who actually first wanted to come up with the defibrillator was someone who taught me, and he said he was at Harvard and suggested that we begin with getting defibrillators. And his mentor said, "What a horrible idea. If you actually take away sudden death, all you got is slow death." Who would want to die slowly? And so he was very bitter towards the end that he never actually got the defibrillator as the credit for it. But anyway, we're going to talk about 2 different types of use of defibrillators, one for primary prevention, and the second one is for secondary prevention. Now for primary prevention, these are guideline-directed therapy, and you do it mostly in symptomatic patients that have New York Heart Association class 2 and 3 with an ejection fraction of 35% or less. And for those that are ischemic cardiomyopathies, you need to wait 40 days. In both the symptomatic and the asymptomatic patients, you really do have to have an overall good prognosis. So you don't want to be giving it to somebody who's about to die. You actually, there is a requirement, the patient has to have a survival expectation for greater than 1 year. In asymptomatic patients, it is recommended, but the ejection fraction should be lower at 30%. I think what's really important when you look at the guidelines is the fact that what is not stated is when do you put them in, okay? And I think that you'll notice that there are differences in patterns of practice among heart failure specialists and other cardiologists. And there's reasons for this very much. So there was a study many, many years ago that Dennis McNamara actually led, a multi-center study that took non-ischemic cardiomyopathy patients, gave them guideline-directed medical therapy, and followed them over time to see how many of those patients improved and recovered their hearts to normal. And he found in that study, when we had almost no drugs, he found that actually 1 out of every 4 recovered to normal, and it took about 9 months. And then he also found that another 25%, actually improved their heart function. That's huge. That's half of the group got better, okay? And because of that, the insurance companies said, are you kidding me? Why would you put them in right away? So when I started practice in 2004, there was a rule from the insurance companies, not the guidelines. The insurance companies said, give guideline-directed therapy for 9 months. And we used to check echoes every 3 months. And by golly, half the patients didn't need the defibrillator. And I'm pointing this out because it's huge. It is a big deal. And so, yes, you can put them in right away, because what really took place when they made that requirement was people complained, my patient's sicker than your patient. How dare you tell me that we shouldn't do this? So actually, there are no rules anymore other than you need to wait 40 days after a heart attack. That's it. But we heart failure specialists usually wait close to 9 months. And we increase medical therapy in patients that actually do not have any symptoms of syncope, of sudden death. So that leads us to the second, which is secondary prevention. And you're really trying to prevent another death. So this is for people who have sustained VT that you see in the hospital, where it's a very long event. It's also for VF, cardiac arrest, and for unexplained syncope. That is the requirements. Biventricular pacemakers are actually for you to feel better, okay? That is the biggest bang. And when they were actually given to patients, patients felt so much better that they actually wondered if their heart had returned to normal. And we expected that. We thought that they would be so much better because they felt so much better. But actually, the national average on all of these multi-center studies was really only a 5% improvement in the ejection fraction. So if you had 30, it went to 35. If it was 20, it went to 25. So it wasn't really actually as big a bang. It was much more about improving symptoms. There were these super responders, and gosh, everybody wanted to be that person who went to normal. And then there were these completely opposite. As soon as you put the machine in and you turned it on, there were these people who actually had a decline in their ejection fraction, which probably has to do with lead placement. And that was a very, thank goodness, rare event. But the majority actually just had improved symptoms, and they also had an improvement in their ejection fraction by a small amount. With that, you have actually an improved survival. That survival benefit is also very small. And I think of the heart as a machine, and when you actually allow the left and the right to push together the blood out, you're improving the efficiency of the heart, and therefore you would expect that the survival would be better. So what are the requirements for a biventricular pacemaker? Well, because it's based on symptoms, you really should be symptomatic. So actually the guidelines are based on having symptoms for the most part, and the ejection fraction should be less than 35%. And it's also based on your QRS, which is, it should be greater than 150 milliseconds. That is the class 1 indication. There are many variations of this. You can do it when it's not a left bundle branch block, and there may be benefit. And this over here shows you all that, but the red is the ones to know not to do. So for asymptomatic patients, there's no benefit if you give it to them when their QRS is less than 150 and they don't have a non-left bundle branch block. And the same is true for class 2. This is just fun for y'all to kind of just see, I think, because often my patients don't know. They said, I got some pacemaker and I don't know if I have 3 wires, 2 wires. So it's actually very easy. You get a chest x-ray and you count your wires. So you can see that there's one in the right atrium, there's one in the right ventricle, and as the arrows point, you have one in the left ventricle as well. And that brings me to our last discussion, which is, when do you put in a mechanical heart? And we put them in on the left side because the benefits are greatest there. When we put it in on the right, there's a higher risk of stroke. But we recognize that these are actually big devices with complications and risks, and that they're really only indicated when people fail medical therapy. And the definition is recurrent heart failure hospitalizations. So I think when you're asking, when do I actually, recommend a patient to have some more advanced heart failure therapy, is when you reach that point that they are having, we call them the repeat offenders. They keep on coming back to the hospital very frequently. And so those patients have choices. We could move towards the LVAD and transplantation, or we could actually be considering, palliative care, such as inotropes and hospice. And those are the decision-making points when we get to that stage. I too wanted to just kind of touch on sex differences, actually, because in 2004, when we had limited devices, that was a real concern. And I think it's important to realize how important you are when you're actually watching patients and you notice things. And at that time, I was noticing that the women I was taking care of that had mechanical hearts were actually having more strokes. But I don't know, maybe it's, at the Cleveland Clinic, but I didn't think so. And I kind of worry that that was, not the case. So we embarked on a big study using the national data, and we found that the survival was the same for women and men at that time. So this is many years ago, and that there was a higher risk of stroke. And now we understand that that is device related. So more recently, there have been several other studies to actually reassess that same question. Is there really any difference in survival between men and women when we put in an LVAD? And there have been concerns that there now, what I saw is no difference. They now think that there could be some differences. So the largest study, one of the largest studies that we had was the EuroMac, which included over 50 countries in Europe and I believe 15 non-Europe countries. And, we have very few women in that study, but there was a higher mortality in the women. However, there's another study that actually was large and there was no difference. So I think that, Dr. Galati's point about the fact that if you don't have enough women, you really don't know. So I feel like that is still an unknown situation for me. What has been discussed many times in other studies have been that women actually will have more RV failure. And I told you that the device really is for people who have LV failure. So if they have concomitant RV failure, that's a problem. They won't succeed. And so there has been found to have more RV failure in women compared to men. And this is based on the EuroMax data. And there was some data from our hospital that also had shown that many years ago. And when we did it and you have a single center, you can kind of look into the reasons why. And what we realized is that women were actually being offered these devices quite late, and that they were also presenting to medical providers quite late. so that the RV failure may have been that we just didn't catch them at an earlier point. There was also a concern I had told you about stroke, and in the Euromax, which is the most recent data, there was no significant strokes in the first 30 days, but after 30 days, there actually was a higher event rate in the women. Here, it breaks it down based on actually the devices, and we have advanced our devices over time. HeartMate 2 actually was a device, and it's the one on the bottom. And that actually is no longer being used, but it did have a higher rate of stroke in women compared to men. That prompted them to actually also, one of many reasons why they actually went to HeartMate 3s, but we have too few patients in that analysis, which is the Momentum trial. And there are no sex differences, but I, again, want you to point out there were only 31 women in that study. And last, there was Heartware, for which actually there was no difference. That is the other device that we utilize that is FDA approved for patients with advanced heart failure. And there was no difference in stroke rate. So in summary, ICDs are for primary prevention to prevent death. For asymptomatic, the ejection fraction should be less than 30%. And for symptomatic, it should be less than or equal to 35%. And in both cases, the patients should have a survival that is greater than a year. For secondary prevention, it's cardiac arrest, VF, VT, and unexplained syncope. And for biventricular pacemakers, it should be after guideline medical directed therapy, and it should be based on QRS symptoms and ejection fraction. And for LVADs, it is still recommended only for stage D as a bridge to transplant or for destination therapy. And that's it.
Thank you, Eileen. Great talk again. Next, I'm going to invite a very good friend of mine, Dr. Mac Ansari. He's an interventional cardiologist down in Texas Tech. He's cath lab director, as well as director of a structural heart program. He's also known to sometimes make some provocative and controversial remarks. So let's see what he has today. Dr. Ansari, he's going to talk about cardiogenic shock.
Thank you. Let me load my slides. Where am I? So, can you guys see my slides?
No, we can't.
Okay, let me see.
Just say share and then.
Yeah, I'm doing share screen, yes. I'm trying. Can you guys see it now?
It's blank. If you have any other windows open, you can close them and just keep
All of them
PowerPoint open. And all we see is a white screen.
Okay, let me try it again.
Yeah.
And share screen. Let me open this. This one, okay, got it. Perfect. Share. You can guys see it now?
Yep, we can.
Okay, great. Excellent. Well, thank you very much for this opportunity. It's great to be among great speakers, and that was a very humble calls to hear. I appreciate it. I'm just going to start with one thing. Our intervention fellow at Texas Tech University is Marina Iskander. She's a female. And while I was hearing all of those wonderful speakers talk, Marina from the back said, Dr. Ansari, this is Woman Power 2020, So this is just amazing. Well, this is a very interesting topic. And why this is an interesting topic? Because there's a lot of misconceptions about cardiogenic shock, even now. And Dr. Gulati mentioned a really interesting thing that we, even though we won't be heart failure specialists or shock specialists, but this actually needs an entire village. And I'll tell you why. So what is cardiogenic shock? When we talk about patients presenting with cardiogenic shock, it's a spectrum of disease secondary to different etiologies. Usually it's myocardial infarction, decompensated heart failure, post-cardiotomy patients. And when we talk about this, it's actually, before coming to the definition, shock is not something that just happens into the hospital. It can happen into the emergency room. It can happen in the cath lab. It can happen during or after surgery, or even in ICU care. That's why it's very important. It's not just the cardiologist or the heart failure specialist, or it's the entire team of ICU nurses, ICU specialists, critical care pulmonologists, different other specialists, because the new definition actually incorporates everyone. And that's very important, to have the early recognition of clinical signs and symptoms of shock, because that's where you can intervene and make a true difference. Because the mortality, even nowadays, can be as high as 40 to 50%. And the reason is about the delayed recognition and what we call about the transfer to the high care centers. So what's the significance of the problem? And that's what it is. Let's say AMI, still the incidence 4 to 8%, mortality rates 40 to 50%. And almost 800,000 Americans have acute MI every year. With the current trends, approximately 60 to 70,000 people will develop shock. And cardiovascular disease accounts for approximately 17 million deaths each year globally. Globally, it's much more different than here in the United States. Why? Because here still there is access to care when people get into heart attacks with door to balloon times being recorded and stuff. It's not the same throughout Africa or Middle East or other Asian countries. So there is a significant difference in that. Now, the significance of the problem is also in chronic heart failure patients. It affects 5.8 billion people in the United States, 23 million worldwide. And look at the cost, 32 billion each year. So this talk I actually modified from just talking about the pathophysiology to cardiogenic shock, because that is something everybody can read in textbooks. I'm trying to move into the systems of care analysis, talking about the cost efficacy, talking about the early detection of the problem, and how to develop programs and coordination in our work with our heart failure specialists. What's the post-cardiotomy syndrome? Low cardiac output syndrome is the most serious complication after cardiac surgery. Incidence is 2 to 14%. Mortality exceeds 20% compared to 1 to 2% mortality of the low-risk CABG patient, and significantly longer ventilator support in ICU patients, hospital stay, or more blood transfusion. And accordingly with this, a significant cost to the healthcare system as well. We all know about the definition of cardiogenic shock, right? Ineffective cardiac output caused by primary cardiac disorder resulting in both clinical and biochemical manifestations. And for ages, we had this chart. Then SCAI, the Society of Coronary Angiography and Intervention, came up with a very nice definition and classification of the stages of shock, in which they actually start with the at-risk patients. So you want to talk about the at-risk patients, the patients who are at risk for cardiac shock, who is not currently experiencing any signs and symptoms. Those are the patients that you want to identify. And then those who are at level B, who are beginning to get the clinical evidence of relative hypertension or tachycardia. Then come the classic signs and symptoms, which is beyond just the volume resuscitation, when you go towards pressor and mechanical circulatory support, including ECMO. Then those who are finally deteriorating because nothing seems to work, and then come the final stage E. Going forward, sorry. Now, what are the clinical consideration of treatment options, right? So first is the medications. The initial CS management relies on inotropes and vasodilators. And why this is important for me to say, so yes, we want to talk about medical management, we want to talk about early detection, we're going to talk about ICU management, but when we talk about mortality risk according to level of inotropic support, why early detection is important. I don't want to seem a person as an interventionist who want to jump to mechanical support, but medical support is important to a level where you have to identify and then talk about mechanical circulatory support. Why? This is the reason. This graphs, actually, this study shows that early mechanical circulatory support could avoid the negative effects of high dose inotrop. You see, when you go towards the moderate to the high dose, to 2 high dose to 3 high dose, you could see the difference that your mortality risk can increase from 3 to 7.5% to as high as 80%. And this is significant. Coming back to the mechanism of action of various devices, everybody knows that. I'm not going to go into details of it, but just to say the more commonly used devices is still the balloon pump and Impella globally. Tandem heart, because of the timing that is required to make the transeptal approach, is not that widely used. ECMO is coming in more with the oxygenation capacity that it carries. When we talk about which device and when to use, so it really depends on the device availability in different labs across the whole globe, which the multidisciplinary team familiar with the device, patient-specific needs, considering the device risk. And this chart actually, it's a really good cardiogenic shock management pathway that describes between reperfusion therapy and going towards durable VAD placement from propalliation towards recovery. But there's another thing to it. It's when you talk about which device utilization. Now that's when Suhail mentions about that I don't want to be a person who could talk about stuff that can create controversy. But what has happened nowadays, when somebody talks about shock, talking about the other management pathways or early detection and the medication, they link shock to just device. And that is something we don't want to talk about because there's much more to it. Because when you just talk about that, what happens, yes, you want to early detect it, you want to use circulatory device, but you want to remember something called upscale therapy. If you directly jump onto bigger devices, then you talk about significant cost differentiation and increment policies where the different hospitalizations is bent upon. So remember, early diagnosis and early MCS intervention is important, but the device selection should be based on risk versus the benefit and the economic impact that comes with it as well. You talk about clinical evidence. I just don't want to go into detail of data, but a nice summary on few things. So the initial data, right? We're comparing the two main devices, and my speaker after me will go into more details about the devices, but I just want to point out a few important things. When we talked about the mortality at 30 days, these are randomized controlled trials. Now the sample size is too low, but these were randomized, and you see the initial data shows no survival benefit in the outcomes of these in these trials. But yes, one could argue that the sample size was very low. Then we talked about Impella CP, which was not associated with lower 30-day or 6-month mortality versus intra-aortic balloon pump. And there was no change in serum lactate levels. So then the question is, why did shock become affiliated with Impella? When somebody talks about cardiogenic shock, yes, I use Impella. There are devices that you want to use to have better outcomes on your patient, but that is not just the only thing. It's much more to it. This is a matched pair intra-aortic balloon pump shock 2 trial 30-day mortality analysis, clearly showing, if you look at the 237 patients treated with Impella matched to 237 patients from the intra-aortic balloon pump shock 2 trial, you can see Impella CP 156, Impella 2.574, 115 with an intra-aortic balloon pump, and 122 with medical therapy. The mortality was 48.5% in Impella versus 46.4% in the shock 2 group. Again, so the takeaway point for this is the timing. You cannot blame one device versus the other. You want to talk about the timing, right? So what's the timing? When you use intra-aortic balloon pump, initially, sorry about that. I'm trying to. I'm trying to take this off. Okay, good. Sorry. Yes, we're talking about the timing, right? So when you use the intra-aortic balloon pump pre-PCI versus post-PCI, this study, the cohort study that was published, clearly shows that there is 25% compared to 55%, and the p-value is statistically significant. When you look at the retrospective study where it was 48 people, 19% pre-PCI versus 59% post-PCI. So you cannot just blame the device when we talk about the timing. So when you use a device pre-procedural, there's a significant difference when you talk about a device post-procedural. Look at the 30-day mortality in MI patients, overall 36%. When you less than 1 hour of the onset of the cardiogenic shock, the p-value statistically significant, 24% versus after 1 hour, 49%. Without going into much details, I'll talk about the safety profiles when we talk about cardiogenic shock. The bigger analysis come back about intra-aortic balloon pump versus no intra-aortic balloon pump. And all these trials that you show about major bleeding were significantly different as portrayed. When we talk about incidence of bleeding between all devices combined to all the procedures that we use nowadays, look at this. When we compare the percutaneous ventricular assist device with TAVR and versus EVA, the two procedures that we do a lot in structural, hematoma 2.8 versus 9.1 versus 10.1, transfusion 24.3% in that TAVR registry versus 17% in the percutaneous ventricular assist device, and re-intervention from 1.1 to 2.6%. So significant difference over there. In the IMPRESS trial, a randomized multi-center study in patients with AMI complicated by severe cardiogenic shock, look at the major vascular complications in both Impella versus balloon pump, and you see the significant difference. And then we come towards the cost. Patients with bleeding, why this is important? Because complications were hospitalized 3 times as long as patients without bleeding complications, and the cost was significantly higher. When we talk about increased costs, that's when the hospital administrators come in between, because look at the difference of cost when you look towards tandem heart or Impella, $74,000 versus $36,000 difference. That's significant. So the take-home message is, we believe in escalation therapy. That's the program we set up over here, that we start with balloon pump, and then we go on if there's not adequate support. But there are patients that directly might need Impella or directly might need an ECMO, depending on the stage of cardiogenic shock that they are present. Not every patient walking into the hospital with early signs of cardiogenic shock require advanced therapy. We keep in mind about the ICU expenditure as well. We keep in mind, but this doesn't mean that we're denying therapy. We're just better triaging those patients. So you have to be aware of the complications, because the first rule of medicine is do no harm. And you cannot just affiliate one condition with one particular device. There is much more to it. When we talk about program development, the main continued challenges of cardiogenic shock, and this is the take-home summary that I wanted to give from my talk, is do we recognize shock early enough? That's one thing. It has to be in coordination with the entire ICU staff, with the entire cardiology staff. Do we recognize which current pathway of care is adequate or inadequate? And what hospital systems are dependent on experience, expertise, and support device availability? A tertiary care center like us, we depend on all the other smaller centers around us, depend on us as being their referral center where there were referral cases. So we have to keep that in mind as well. So this is the designated level of care strategy. Level 1, which is a referral resource for other communities and nearby regions. You establish the team and process and able to offer an exit strategy for them if they cannot provide that level of therapy. Level 2 is the 24-hour critical care expertise, like those who can give mechanical circulatory support, be it balloon pump, Impella, or ECMO. If decided to include VAD, would need to have an alliance with the transplant program with our CHF colleagues. And level 3 would be the prompt assessment stabilization protocol for transport. So it's not just a hemodynamics or inotropic support, it's a whole team taking in mind the respiratory condition and reaching the potential treatment options for our long-term girl benefits. So this is our experience in Lubbock, Texas, when we started the entire shock phenomenon over here, shock program over here 4 years ago. And we have data that suggests that we have significantly decreased the mortality of surrounding areas by educating them and making teams with that as much as 50% in the 4 years that we have gone on to this program, which is a significant achievement in this West Texas. So how do we go on to this? There needs to be an expert consensus that specialized centers have more tools to offer, protocols for treatment, protocols for the transfer, and recognition that current treatment is not enough. So avoidance of futile care and excessive expensive. You cannot have a program which is just bent upon directly jumping up to bigger devices. Thank you very much. And I would be welcome any question towards the end. I hope I made my time. Thank you.
Thank you, Mac. And if you can unshare your slides so that our next speaker can get his set up. And it's my pleasure to introduce the next speaker is Dr. William Suh. He was formerly at UCLA and is now at Riverside Hospital. For those of you on Twitter, you may know a little bit about what is going to be coming towards us now. And we're excited to hear his talk on mechanical unloading in acute MI. Thanks for being here.
Thank you, everybody. Hope everyone is staying safe and doing well. Can you hear me? Can you see my screen?
We can see it and hear you. Thanks, Will.
Great. So today I'll be talking about a very interesting concept of mechanical unloading in acute myocardial infarction. Here are my disclosures. I am a TAVR proctor for Edwards Life Sciences, but I do not have any financial interest related to this talk. So more than 6 million Americans are living with heart failure, and over 550,000 new cases are diagnosed each year. Myocardial infarction is the leading cause of heart failure. Some of the mechanisms of how MIs can lead to heart failure include myocardial necrosis, ischemia, reperfusion injury, inflammation, fibrosis, and LV remodeling, among others. So 25% of patients will develop heart failure within 1 year of their first MI, and up to 75% may develop heart failure within 5 years. So we need strategies to limit the insult and injury to the heart. Primary PCI and trying to achieve door-to-balloon times of less than 90 minutes has been the main strategy for rapid reperfusion and improving outcomes such as mortality and heart failure post-myocardial infarction. Decreasing door-to-balloon times even further may improve survival more, as seen in the study done in South Korea. Every reduction in door-to-balloon time showed continuous reduction in mortality. However, decreasing door-to-balloon times below 60 minutes is difficult to implement for a variety of reasons, including patients delaying their presentation, as well as logistical issues like staff needing to travel to the hospital when they're on call. So the main goal of primary PCI is to restore normal blood flow and minimize myocardial injury. Advances in cardiac MRI imaging has made it possible to more accurately measure infarct size after an MI. Greg Stone, in this study with his colleagues, analyzed 10 randomized trials and looked to define the relationship between infarct size and outcomes. These are the 10 RCTs that were analyzed on the left. Infarct size was measured either by cardiac MRI or SPECT nuclear imaging within 1 month of the acute MI. They looked at mortality, reinfarction, and heart failure hospitalization as the outcomes for their study. This was the central illustration for their study. Death or heart failure hospitalization was observed in 8.8% of patients in the 4th quartile of infarct size, whereas death or heart failure hospitalization in the 1st quartile was observed in a much lower 1.2% of patients. So the conclusion of the study was that infarct size may be useful, and I emphasize maybe, as a surrogate clinical endpoint and an important prognostic measure when caring for patients with STEMI. So as mentioned earlier, ischemia, reperfusion injury, and post-infarct inflammation may play a significant role in the extent of myocardial injury and infarct size. And animal studies over the last several decades have actually looked at the possibility of unloading the left ventricle, decreasing the cardiac power expenditure, and to see if that can help protect the myocardium and reduce infarct size. So in this pig study performed by Naveen Kapoor and his colleagues, 30 minutes of left ventricular unloading with the Impella percutaneous LVAD prior to revascularization was associated with decreased infarct size compared to revascularization alone. The concept here is that LV unloading reduces cardiac power expenditure, decreases the physical forces on the injured heart, protects against ischemia reperfusion injury. Ultimately, the goal is to save as much myocardium as possible and minimize infarct size. And the development of the Impella family of percutaneous LVADs and animal studies like this one have really energized the research field in studying the process of mechanical unloading as a cardioprotective measure in acute MI. So here is one definition of acute cardiac unloading. Acute cardiac unloading is any maneuver, therapy, or intervention that decreases the power expenditure of the left ventricle, limits the hemodynamic forces that lead to ventricular remodeling after insult or injury to the heart. So these are some of the types of devices that can be considered, and these are the tools in our armamentarium. So let's look at some of the data, and let's first start with the balloon pump. So conventional wisdom number one, the balloon pump is beneficial in patients with acute myocardial infarction. The CRISP AMI randomized trial looked at infarct size in patients with anterior MI without shock. In this randomized trial, the balloon pump plus primary PCI did not reduce infarct size compared to primary PCI alone. So this was a negative study. So this conventional wisdom was therefore busted. So let's look at another conventional wisdom. The balloon pump is beneficial in patients with acute MI and cardiogenic shock. So the IABP Shock 2 trial was a randomized trial looking at balloon pump and to see if it will improve survival in patients with myocardial infarction and cardiogenic shock. The primary endpoint of this study was 30-day mortality, and there was no difference between the groups treated with the balloon pump versus the control group. So another negative study for the balloon pump, and therefore this conventional wisdom also was busted. So we use balloon pumps frequently, and oftentimes we do see some hemodynamic improvement once the balloon pump goes in. And so why didn't it work in these trials? Well, the balloon pump can only supplement cardiac output by about ½ liter per minute, and it does not effectively unload the left ventricle. So the power of Impella must be the answer. We'll see. So let's replace the balloon pump in this conventional wisdom and make it an Impella. So the Impella must be beneficial in patients with acute MI. This was a study done by Dr. Kapoor, who did that initial pig study. And this was the door to unloading pilot study. These were patients that had anterior STEMI without shock, and they were randomized to left ventricular unloading with immediate PCI versus LV unloading for 30 minutes and delayed PCI. And their primary endpoint was looking at infarct size. The primary endpoint here was no different, and LV unloading and delaying reperfusion 30 minutes did not reduce infarct size, unlike the study, the pig study and the pig results that showed that there was a reduction in infarct size. So there was concern among the interventional community that the 30-minute delay could be potentially harmful. We are under this wisdom that time is myocardium, so you want to open up the artery as quickly as possible. So would that 30 minutes actually increase infarct size? This pilot study actually showed that the delay of 30 minutes did not increase infarct size. So this study did not identify any prohibitive safety signals that would prevent moving forward with the pivotal randomized trial. So that pivotal randomized trial is the STEMI DTU trial. And this will randomize patients to immediate PCI without LV unloading versus LV unloading with the Impella CP device and delaying reperfusion for 30 minutes. This study will also look at infarct size as well as important clinical endpoints. But for now, this conventional wisdom is also busted. But as I said, the STEMI DTU trial is underway and recruiting patients. And if positive, this could be very disruptive to how we approach patients with anterior MIs and acute MIs. And it could be similar to how primary PCI was disruptive and changed the paradigm of how we treated these patients when in the era of thrombolysis. So lastly, let's again look at and replace balloon pump here with Impella. And we got conventional wisdom here that Impella must be beneficial in patients with acute MI and cardiogenic shock. Dr. Ansari already mentioned the IMPRESS trial, and I'll repeat it here, but the IMPRESS trial was a randomized trial looking at patients with acute MI with cardiogenic shock. And at 30 days and at 6 months, there was no difference in mortality between the groups. Dr. Ansari also mentioned the IABP Shock 2 matched pair analysis. This study, this analysis did not show any observed differences in 30-day mortality versus balloon pump and in the Impella. But there is an ongoing randomized trial in Denmark and Germany looking at the Impella CP device in acute MI. And so we are eagerly awaiting the results of the trial, but I understand that the enrollment has been slow, so we might be waiting a little bit longer. So, but for now, this conventional wisdom is also busted. So in conclusion, Thus far, there is no positive randomized controlled trials that exist demonstrating benefit of any mechanical circulatory support device in the setting of acute MI without cardiogenic shock or acute MI with cardiogenic shock. However, this concept of mechanical unloading and cardio protection is of high interest and has the potential to create a paradigm shift in our revascularization strategies. However, we'll have to wait for the STEMI DTU randomized trial. So thank you for your attention.
Great, thank you, Will. That was wonderful. You know, there's so much controversy in this space, and your Twitter push to have a randomized trial for Impella is compelling. I don't know if anyone will do it, but let's move on to our next speaker. Dr. Van Spal is, I think she keeps seeking me out to get back at me for a picture that I took while she was tired, but she was giving a talk. So my apologies. It was not.
I will get you back, not to worry. It's a matter of time. It's coming.
I'm a ninja. But she's an associate professor of medicine. And you know, just a wonderful speaker. We're hoping to hear some ideas on leveraging technologies. We're there. I think we have the infrastructure. We're building the infrastructure. We have the technologies available, cloud services, etc., FDA cleared devices, and how do we put these all together? And so, Dr. Van Spal, let's see what you have for us.
Can you see my screen?
Not yet.
Okay, I've shared it. Let me go back into Zoom, and I'll have you allowed me to share.
Let's see here.
Let me see.
Yeah, I think, let's see, Will's
Are you
on
seeing it?
Do not see it yet.
Oh, here. Okay. So I go into share in Microsoft PowerPoint, which it is, and I hit share, and it's open system preferences. And just let me try again. Can you see it now? Slideshow?
We can't hear it.
Really?
Not at all. So you shared your screen, right?
Yeah.
Okay, I don't know. And you don't have it already open as is?
Share screen. Should I not just go under Microsoft PowerPoint?
You should, as long as it's not open in your background, like already playing in the background. Otherwise, just close it again and just try one more time. I apologize, and sorry for everyone on.
Wonderful. Why is it that the last talk is always a problem, isn't it? Just when everyone wants to wrap it up, right?
I don't know. We're admiring your background at your cottage, so we're like all liking that part. So I actually was glad you hung out for a while in the picture position. Do we have a technical help on that can?
Okay, so view. So, okay, I'm going to go back into Zoom, and if not, you know what? We'll just give people a break.
You can also try to log out, like leave the meeting and sign back in and see if that helps.
Harriet, were you sharing your slides from Zoom or sharing them from PowerPoint? Because you have to hit the share screen button in Zoom.
Yes, that's what I'm hitting.
Okay. Got it.
And the other option is I could email it to you quickly. Can I do that, or?
Yeah, you can do that.
Yeah.
Okay. Do you guys want to take questions in the meantime?
Sure.
Even if you don't show slides, are you able to just talk through them since you can see your slides?
Yes, I could, but should I? So, Hale, should I email them to you? I have you.
Yeah, sure. You can email those to me. That's fine.
Okay.
Go ahead.
Okay. In the meantime, why don't we have a couple of people answer questions so that
Right.
Yeah.
I'm gonna ask, we can actually ask
organizers out.
Michelle a question while we're waiting for this to get up. I actually wanted to ask them both, since they both kind of touched on and showed a couple of the same slides. You know, we have all these proven guideline recommended therapies, which are excellent. But at some point, if we start listing all the medications in addition to the heart failure medications that patients will need, I guess how many medications are too many? And since we don't do such a great job with even the older medications, and now we're introducing all these new ones, sort of how do you balance that in your patients? I mean, you gave a nice step-by-step, but in reality, how do you do that?
I think you said, I'll give that one a shot. Okay, so perfect is the enemy of good, ultimately, right? And you want to get patients on something because something is better than nothing. I mean, VHEFT 1 in 1986 showed us that isodrone and hydralazine is better than placebo, so something is good. But listen, I always try to divide things into what is the medical ideal. The medical ideal is quadruple therapy, no questions asked. And then once you've established the medical ideal, then you say, okay, what's the reality? And yes, I have patients who can't afford their copay for their ARNI and have 100 side effects to their beta blocker and get gynecomastia with both mineralocorticoid antagonists, which I find mysterious, but happens. And I can't take an SGLT inhibitor. Of course, all of that happens. So that's one level. The financial realities we can't get around, the side effects we can't get around. But there's sometimes the contraindication or the resistance is a level of resistance on the patient's part that isn't based on finances and isn't based on side effects, but just based on, I don't feel like doing it. And I think that's where our ability to communicate and gain trust with the patient comes into play. Like, I don't really care if you take that pantoprazole if you really don't have GERD, and honestly, the allopurinol, you haven't had gout in 5 years, but let's focus on what really will help you feel better and live longer. And I think you get a buy-in because sometimes when they start some of these medicines, they actually feel better. So that's my take on how to get around some of the potential softer barriers to prescribing the meds.
Thank you, Michelle. Nasreen, did you have anything to add on that?
I would second the cost issue. I think it's a very real issue that, you know, and I say it all the time, we keep getting these new drugs on the market that are amazing. They reduce morbidity and mortality, but we also have to make sure our most vulnerable patients can access them. So I think cost is a real issue. We should not pretend like it's not. I think we have to talk about that in the guidelines and any consensus documents, that cost is really prohibitive in some patient populations. And I would say, like Dr. Kittleson said, you have to go through the medications, and a lot of times you find that patients are on 20 meds and maybe 5 of them, even 10 of them, they don't really need to be on. And not just patient inertia, I think it's clinician inertia too. You hear it a lot, my patient's doing fine, why should I change anything? Well, you should change things because we're long-term risk. Dr. Kittleson mentioned the 6.3 years added life. So I'm not talking about here and now, how you're going to feel in a couple of days. We're talking about long-term risk reduction. So I think education and advocacy are both important things to ensure our patients are on the appropriate therapies.
Great. And somebody actually
Martha, can I add something? I'm going to take a slightly different approach because I do think that that's a problem. You know, too many medications, and there is that ideal world which Dr. Kittleson had brought up, and but I want to remind people the basics. You know, when we started with ACE inhibitors, patients, it was the first drug that actually had some remodeling benefit, but people were not cured. Okay, they were not cured. Okay. We started beta blockers, and all of a sudden you had people remodeled to normal. Okay, very big point. So in Greg Fonaro's, slides where he shows the big bang, beta blocker is #1. And so my patients will tell you that they know that if there's a drug that they cannot miss, it's their beta blocker, because that is going to get them the biggest bang. And then the next, question that comes to mind is the African American population. You know, we already have a study dedicated 100% to them for hydralazine and isodone. I know you know where I'm going with this. And then you throw in ARNI, you know, and, you know, at what point, when the blood pressure starts to tank, do you think one is more important than the other? Okay. And I think we have to look at the race as well as actually what the benefits were. So if we had only, you know, you had brought up how the women are often underrepresented. If there was a study just on women and they were well represented and it was an incredible drug, then that should be the drug that we push harder on for that population. So I think that we really do have to keep in mind actually the race and the sex. And I really strongly push my beta blockers before all else. So I don't keep adding a whole lot of stuff. I really wait to see if I can normalize my patient first, and then I start adding it.
Those are really great points.
You know,
And
there's
somebody in the audience said is that, you know, that pharmacists utilize your pharmacists. And I think that that's a great point of reminder. So we still aren't seeing the slide. So I was going to ask Michelle a question that seemed to be directed to her. Maybe you answered it, but I wanted everyone to hear it. Somebody asked, is there a therapeutic benefit of low dose SGLT2 inhibitor if a patient can't tolerate the higher dose?
So if you look in the randomized trials, the incidence of hypotension between the groups, there's no significant difference between the SGLT2 inhibitor and placebo. And even in my clinical practice, I haven't seen that. And if there's subsequent studies that indicate the millimeter difference in the systolic blood pressure is pretty minimal. So I don't think that's going to necessarily be a major factor. If it is, you'd be in a data-free zone outside the trial to publish it, but I would say start by trying the 10 milligram dose. I don't think you'll find a dose dependent significant degree of hypotension. And you can always drop the diuretic and that may help.
Okay. And Dr.
So I have emailed my slides to Sohail. Apparently he's recording, so he can't open them. And I do this all the time. I have 3 or 5 presentations every week, and I've not had trouble before, so I'm not sure what's going on. I'm going to try one more time to share my screen.
I just received your email like a second ago. Let me try to open it, okay?
I was just going to throw in there that the caveat with beta blockers is there's just been one with a head-to-head trial that demonstrated efficacy, you know, and so I feel that carvedilol is really underutilized in clinical settings. I would say that in patients with HFrEF, it really should be the go-to beta blocker. And the caveat with ACE inhibitors is that it's been proven efficacious in the post-MI setting, and clinical trial for an ARNI in that setting is still pending. So that's one setting where I would choose an ACE inhibitor for patients presenting with de novo heart failure in the context of post-MI. And then we're going to get my slides up and running, and hopefully there's like 2 or 3 people still left to hear this talk.
We have
There's
89.
a lot of people still left, and actually, Harriet, there's 90 people on.
Okay,
if you can just tell us as we go through, just say next slide, and we'll move your slide.
Wonderful. I'm honored to be here. Thank you for letting me speak about digital health technology to optimize heart failure care. I have no industry disclosures pertaining to this talk. Next slide. I will go over in the next 12 minutes the domains of digital health. We use terminology and not all of us are up to speed with what some of that means. I will give you a very brief overview of platforms and apps for digital healthcare, discuss some tips and tricks for a successful virtual visit with your heart failure patient, and touch upon some evidence that supports the use of digital healthcare in heart failure. Next slide. So what is digital health? Next slide, Sohail.
I am trying, here we go.
The World Health Organization, I'm very demanding, but the World Health Organization defines it as information and communications technology for healthcare. But in the current era, it's so much more than that. It encompasses mobile apps that include personalized healthware, including wearables and implantable sensors, telemedicine, so innovative ways for us to connect with patients that precludes the face-to-face visits that we've become burdened with. Clinical information systems, so EHRs, allow us to have information at the tip of our fingers, integrated networks that allow us to speak to other healthcare networks and give us the allowance to do things like e-prescribe, and big data that afford us the opportunity for analytics, artificial intelligence, machine learnings, and fabulous ways to enhance patient care. Next slide. A focus of our care in the last few months in the setting of the COVID-19 pandemic has been telemedicine. It's sometimes called virtual care. What is it? So it basically has patient-facing technology that allow us to collect data that is either transmitted electronically and digitally through Bluetooth technology. And this could be devices that the patient wears, or traditional blood pressure cuffs and weighing scales, things that are digital. These could be transmitted automatically, or the patient can manually enter these parameters or call us via the telephone and give us the data. When entered digitally, it is transmitted to a cloud-based system that is then accessed by the clinician. In the olden days, clinicians would tell the patient, or a nurse would tell the patient based on certain red flags to go to the emergency department. That's far from ideal care, which really should close the loop of communication, based on that data, come up with an action plan and implement it at the point of care. Telemedicine often also involves video conferencing, where we can directly communicate our findings and our impression and plan with patients. Next slide. The concerns around this are governance: who owns the data, how is the data stored, who accesses the data, is it HIPAA compliant? I've come up with a list of generic platforms that, in absence of proprietary, expensive healthcare specific platforms, can allow you to visit with your patient virtually. These are for the most part not HIPAA compliant, but in many jurisdictions in the setting of COVID-19, some of the HIPAA regulations have been lifted to allow clinicians to provide practical care that's convenient to the patient and also affordable to the clinician. So these selections involve Apple, Google, Zoom, Skype, Microsoft Teams, Cisco, Amazon, and they can allow us the opportunity to connect with our patients for clinic visits. Things to keep in mind is that patients need to provide you with consent. They need to know that some of this may not be HIPAA compliant. They need to know that their data is at risk for breaches and security. You as a clinician need to know that some of your privacy settings need to be changed to safeguard your own personal information so that you're not accessible 24/7 to everyone. You need to know what your HIPAA compliance means, what the regulations are in your jurisdiction. And of course, you need to know whether these platforms integrate with your EMR, whether your patient has broadband access, whether they have the appropriate devices to use these platforms with you. Things to also keep in mind, next slide, are the technical language and cognitive abilities of your patient. We know that many patients with heart failure are elderly and do not have normal cognitive function. The bane of our existence in virtual care is the physical exam or lack thereof. But there are important data points that you can get through virtual care platforms. You can get vital signs from your patient if they have devices in their home or if you set them up with the devices. You can look at their list of medications. You can look at their neck. You can visualize their respirations. When they speak to you, you can assess whether they're short of breath, whether they're wheezing. You can ask their family member, who I always traditionally engage in these visits, to palpate their belly to see if it elicits any tenderness. You can ask them to come prepared with socks off so that you can look at their ankles, get them to palpate their ankles for you in front of the video. And oftentimes elderly patients can't do this themselves if they have limitations, but a family member can certainly do that. Next slide, please. I will skip the slide. It basically goes over some of what I've already discussed. In the era of pocket echo, some companies allow echocardiography to be feasible in the patient's home, and this is something you can also do. How do you prepare for a successful visit? So first of all, you determine which platform is suitable for your patient. For some patients, telephone or FaceTime suffices. Some patients need more than that for monitoring. Ensure that your patient has provided consent and document it in your dictation or notes. Schedule an informal or formal caregiver to be present. It really makes the visits so much easier. Select a quiet professional space to talk in. Consider having your EHR open if you don't have an integrated platform so that you can have all of the data pieces at the point of care. I always ask for the updated medication list to be sent from the pharmacy. Well, my assistant does that and uploads it for me so I could see in real time the current list of medications. We have the vital signs and weights transmitted prior to the clinic. And again, it's available once I open up the platform. And then we ask for patients who need special instructions to have those instructions received prior to the visit so that they can come prepared and we don't sink time asking them to take their shoes and socks off, for example. Next slide, please. During the visit, start by confirming that the patient can see you and hear you and that they can see your slides if you're giving a slideshow. But you want to listen actively and watch your tone. Physicians can often interrupt patients, and somehow we get away with it in face-to-face encounters. Interruptions don't go so well in virtual visits, so it's important to actively listen. Ask your patient to write down recommendations that you give and also questions that come up during the encounter so you can address them at the end with limited back and forth interruptions. If there's need for remote labs, diagnostic studies, particularly in this COVID era, address the need for that and have an ambulatory point of care provider set up so that they can go to the patient's home to obtain some of these data points. Consider digital prescribing. There are many apps linked to your pharmacies where you can e-prescribe and it prevents the patients from having delays in their prescriptions being filled. And then end your visit by summarizing the action plan so that the patient can write it down. Next slide, please. Document your visit, even though it may just be a telephone consult. Arrange for follow-up care. So have a mechanism in place so that your assistant automatically follows up on these patients in case you don't have virtual care as your normative mode of care delivery. Don't forget to bill for the encounter if you're in a fee-for-service system. And then consider capitalizing on external or internal sensors if your patient needs extra monitoring, such as ECG monitoring. Next slide, please. This is a summary of external and internal sensors that you can use to your advantage. So external sensors are those that the patient wears on the external surface. They include smartphones, wearable sensors such as skin patches or wrist sensors, ECG monitors, brachial cuff sensors. All of these, through a variety of different technologies, can sense heart rate, blood pressure, SATs, and transmit that information to you. Internal sensors are those that many of our patients have, so pacemakers, CRT devices, pulmonary artery pressure sensors for those who have cardiomems, for example, left atrial pressure sensors, and then ingestible sensors, which I really don't have in my patient population. Next slide, please. So what is the evidence to support some of these interventions? This is a network meta-analysis that we led looking at various interventions and ways of organizing care for patients who are hospitalized with heart failure. And we looked to see how they compare to each other for the endpoints of all-cause mortality and all-cause readmission. We found, at least in the era leading up to 2017, that telemonitoring and telephone support in and of themselves did not reduce any of these endpoints. So all-cause mortality was not significantly reduced. Next slide. And all-cause readmissions was not significantly reduced among patients hospitalized for heart failure. Next slide, please. However, these technologies in the current era are quite different because they are more comprehensive and they allow for face-to-face connectivity, which we know patients enjoy and which facilitates adherence. In a small pilot clinical trial that assessed the feasibility and safety of virtual care versus in-person clinic visits following heart failure hospitalization, virtual visits was slightly but non-significantly better in the rate of no-shows. So fewer no-shows with virtual visits than inpatient visits, or in-person visits rather. Next slide, please. But of course, with a trial of this size, which was just not powered to show any difference in clinical endpoints, there was no significant difference in clinical endpoints, although a trend in terms of the hazard ratio that was favored, that favored the intervention or virtual care group in the composite clinical endpoint of all-cause readmission, ED visit, or death. Next slide, please. In another trial, so this is a platform that we are testing in a clinical trial. We have a virtual care platform that we designed that integrates with EMRs, with a laboratory so that we can e-prescribe, with video conferencing, and with devices. And we are assessing the efficacy of this intervention in the post-hospitalization phase and in the ambulatory clinic phase, and also at the end-of-life care phase. Next slide, please. So in summary, digital health is cool. It allows for great, convenient, and patient-centered ways of delivering care. It includes mobile health, remote monitoring, telemedicine, and e-prescription. Practical tips: tailor the services to the level of care that your patient needs. Not everyone needs the comprehensive digital platform. Select a platform that's appropriate for your practice, keeping in mind HIPAA regulations and also patient consent. Create a scheduling protocol that does not allow patients to fall through the cracks in terms of follow-up, because this usually deviates from the usual clinic bookings. Obtain consent, document your visits. The benefits are limited to very small clinical trials that have shown safety and feasibility. Improved outcomes remain pending in larger, appropriately designed trials. And the risks are really, and the limitations: broadband access. You have to think about equity and equality, because there are patients in lower socioeconomic neighborhoods that do not have broadband access. For us, our Indigenous people do very poorly and do not have broadband access to afford these technologies. Think about the technical, cognitive, and language limitations of your patient, and always privacy, safeguarding the patient's interest. Thank you so much for this opportunity. I'm so sorry the slides didn't project earlier.
Oh, Harriet, that was an excellent talk. So I have a question for you. So the people that, it's continuing the disparities in some ways with telehealth. It seems that the people that already don't get optimal care in our current health system are also the people that probably can't even take advantage of telehealth for a variety of reasons, as you outlined. Is there any data right now? I know some people are looking at it, but are you aware of any data looking at that, and then strategies that people have used to try to improve it? I don't mean it from the billing standpoint, but just how we can, what are potential ways we can improve their access?
So access is a big issue for most underrepresented groups. And those groups traditionally don't do well in our healthcare system at the best of times. And we just don't know the impact of these kind of interventions on patients who are at a certain socioeconomic level. They're certainly not represented in clinical trials to begin with. And people with language barriers, cognitive impairment, they're typically excluded from clinical trials. So I would say that that's a risk. At the same time, it could be a tremendous benefit, because there are people, for example, who have poverty as a limitation to come and visit you in clinic. Oftentimes they have to have time booked off from work, or have their adult child who's being paid hourly wages take time off work, come to the hospital, park, pay $20, and sit and wait in a clinic setting for you to see them. So we have pilot data that patients consider these kind of technologies more accessible and more convenient, and that it actually occupies less time on the patient's part to attend to a visit and get an action plan in place. We are measuring a whole array of patient-reported, patient-important outcomes, in addition to the traditional outcomes that clinical trials are great at measuring, because it's such an important part of the patient's outcome. Their experience of care helps them adhere or discard a modality of care delivery. So important point, one that we're looking at.
Great, thank you. So Dr. Sula, are you still on with us? I had a question for you. I just wondered if there was ever any place that you saw right now a role for Impella.
I think that we need more studies. I think that there is a role. I think that it's all about patient selection and knowing which patient may derive benefit. You have to balance that with the safety concerns that Dr. Ansari brought up in his talk. I mean, bleeding is a big issue. The technology is getting better. Abiomed is going to be coming out with a 9 French device, so that would help improve safety. But there's a lot of other issues involved in terms of hemolysis, management in the ICU, malpositioning. These are all things that need to be worked out and to help improve the outcomes of our patients. So I think that the role of the Impella should be in the setting of a clinical trial. I think that would be the best way to get our answer of how to treat these patients.
Can I just add a point that, Martha, I know you won't mind me adding this point, but the majority of people with cardiogenic shock in the post-MI setting are women, females. So 60% are females, and less than 30% of trial participants in these cardiogenic shock trials are females, about 25% in fact. So given that the frequency of these events is relatively low, the trial populations are small, we talk about needing more trial evidence. We should add that to date, there's such a dearth of evidence in females, and any clinical trial ethically needs to target an enrollment that represents the prevalence of disease in females and males. These devices are all designed for bigger people, right? And males primarily.
And that's the problem, I think, in devices in general. Women have often been underrepresented before they've been, and then they get rolled out, and we don't have the data if they work well in women or what the risks are for women, where there are risks in these therapies. Well, my co-moderators, I've been hogging all the question periods, so I want to make sure that if you guys seen any other questions that have popped up on the side or questions you had for other speakers.
Dr. Gulati, can I ask a question to all the panel? I have this question because this was a great talk for heart failure from all the specialists. I just want to know at different centers, what is the mechanism of collaboration for shock teams between heart failure and the interventional cardiology setup? So if every member of the panel can give a statement on that, I would really appreciate it.
Sure. Viet, do you want to give your view?
Yeah, I mean, at Intermountain, it's been led really, interestingly enough, by our structural team, who collaborate closely with the heart failure team. So at our facility, Brian Wisenet has done a great job of onboarding CT surgery and getting the structural part together, interventional cardiology and CT surgery. But heart failure, you know, we commonly have rounds with them, whether it's echo rounds, valve rounds, etc. So the team's always together, and we discuss these things. So,
sure. Michelle, do you want to tell us your experience at Cedars?
Sure. So we don't have as yet a formal shock team. That will take approximately 37.2 additional meetings and 174 man hours before that actually comes to fruition. But the way things work is, it happens to the point of entry. Did they come as a transfer to the heart failure service? Did they come as a transfer to CT surgery? Do they show up in the cath lab? And then you activate the other expert you need. So if I have a patient crashing and burning, I will call my interventional expert wizard to put something in, and or call the CT surgeon if I think they need something bigger, and vice versa. They'll call us if they put one of those devices in. Once the patient's in the hospital with the device, the heart failure team drives the bus. I mean, we are the head and the heart of the operation, right? And then consult with them for troubleshooting the devices.
Thank you. Harriet, do you want to give us the Canadian perspective? Oh, you're on mute, dear. Harriet, you're on mute.
We don't have a shock team yet.
Okay, all right, sorry. Nazreen, are you still on with us? Can you
I
give
don't
us?
know if the Canadian believes in impeller device because of the cost. What do you think?
There is some utilization of it. I would say that we're quite evidence informed, and there are less financial drivers to the care we provide. So, you know, there's less of a hospital monitoring, you know, regarding revenue. I mean, it's an important consideration. Cost is an important consideration, but when there's a lack of evidence to support an intervention, that should be the main driver of whether you use it or not, right? Cost is secondary in that regard.
Great. Well, I guess we came up to the top of the hour, and we've taken up 2 hours of people's time. So we do want to be respectful and try to be on time. Don't forget to claim your credit. If you don't, we had set up our website so you can either scan and get your CME, or you can, if you somehow lose that, where you registered, you can get the information as well. I'd like to, again, take the opportunity to thank all our wonderful speakers. I mean, you are all amazing. And I think everyone knows that we had the experts on tonight. So we appreciate it. Some of you were on vacation and still made time to come and be with us tonight and teach us such great things. And to my co-moderators, thank them, because they were really the brains behind all of this and organizing it all as well. Sunil, do you have anything you needed to say before we close off?
Well, that's all. Thank you, guys. This was a great webinar, and thanks for your time out of your very busy schedule. Once we download the recording, we will upload it on YouTube, and the link will be sent out. And we will also, of course, tweet it tomorrow. And if you have any questions, please email us, tweet us, and follow us. And we will be back with another webinar in next 2 to 3 months. And we are deciding we should focus on vascular disease or structural heart disease. But me and Dr. Gulati and Piet will talk about it, and we will keep you posted. And thank you again.
Thank you. You did a great job.
Thank you.
Thank you so much for the opportunity.
Thank you. You take care.
Yes,
Thank you, everyone.
Bye, guys.
Bye.
Good night.